You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. This is part 2 of our conversation with guest Tim Pletcher, the Executive Director of the Michigan Health Information Network. Dr. Pletcher talks with our regular panel, Gary Austin, Ken Kleinberg, and Jocelyn Keegan, about the role of HIEs in healthcare and public health. I hope you enjoyed today's podcast and that you'll share your topic ideas with us by emailing us at podcast@pocp.com.
Good day, everybody, and welcome back to the ongoing adventures of The Dish on Health IT. This episode is part 2 of a 2-part conversation with MiHIN Executive Director Tim Pletcher regarding the role of health information exchanges in a post-COVID world. I'm your host, Gary Austin, affectionately known as Lumpy, coming to you from Las Vegas. We as Point of Care Partners are health IT consultants with 100-plus associates in over 35 states. We work across all stakeholder groups and are considered an independent, trusted party, the Switzerland of consultancy. With me, as always, on The Dish on Health IT are my 2 co-hosts, Jocelyn Keegan and Ken Kleinberg. Now, let's carry on with our conversation with Tim. So Tim, tell me a little bit about new HIE services that you guys have brought on board due to COVID. You know, you've had some probably requests from your constituents to say, I need this or I need that or whatnot, and probably some you brought on, some you couldn't bring on for whatever reason and whatnot. Kind of talk us through that a little bit.
Sure. So, back in March, we actually segmented the organization and said, okay, all of you, business as usual. This group over here, you're our COVID response team. You get everything you need, whatever that is. You are the highest priority. If it goes on your wish list, it happens. Everybody else, we reprioritize and rebaseline. And that COVID response team got bifurcated into 2 groups. One that was focused on remote care and actually helping doctors whose offices were now empty and getting HIE services and telehealth remote care services up, running, activated. We put a team of about 9 interns who, interns were having trouble getting jobs too, but we put them all together to say, okay, launch this telehealth service. And that's been very supportive and effective at a time when a whole bunch of, it's just a good time to be in the telehealth business. And we'd started on that journey earlier, but we really ramped it up. The second was support public health no matter what they want, whatever they want, wherever they need it. That was largely focused on Detroit, the city of Detroit. We didn't know the city of Detroit, mayor's office. We did not have them under our legal framework. All of that happened really quickly. And one of the things we've worked hard is to have a common agreement throughout Michigan for how everybody is legally connected to the network. And that didn't change. We just accelerated that process. That brought on the point of care testing labs, the drive-by labs, the things that were not already part of our lab flows. So there was an awful lot of bringing on new partners for that. Specific shout out to APIs. There are a few point of care lab testing things that would be great if they were not batch oriented because they do the test in 15 minutes, but apparently it still takes them 24 hours to send the batch file. But connecting lots of different labs and then moving very quickly to reporting and taking the data out of the data lake, establishing what we call a COVID registry on top of our active care relationship service, and then returning back, COVID lab results back to folks, not necessarily who did the ordering for the test, but who basically routinely saw or cared for the patient. And doing all that really quickly, we went to a next generation of our technology that we use. We have something called the Active Care Relationship Service that basically maps out how everybody is connected to the same patient. And we migrated that over to a graph technology, which gives us sort of phenomenal speed and performance and very unique reporting capabilities. And that is what we use to create a COVID registry, which we can then sort of also use as we look at employers and how to sort of take, which employees are connected to which employers, to which doctors, to which health plans, et cetera. So, I mean, it's a very powerful set of infrastructure that we accelerated by 6 to 9 months for production than we originally anticipated. And then our data lake and analytics has taken on a whole new relationship with the state public health team, where there are 2 epidemiologists sitting, not physically because we have to be socially distant, but actually given access, working hand in hand with our analytics team so that they're guiding the kind of reports that are run from the data lakes. But then the other thing we've had to learn is, we have great ideas on technology and where we should go, but you got to take your instructions from the National Guard. They're not interested in 2 weeks from now. They're not interested in a month from now. Right? They're interested in what problem can we solve right now, tomorrow on the ground, because that's bigger. And so we've really adopted a support mindset, which has helped us with our relationship building, because we were always, we got to do APIs, we got to do the next technology. And they're like, no, you got to help us right now. And I think as we've learned to do that, we're now that everybody's got a little bit more room, being able to say, well, what about this? Or, kind of waiting to be asked. When they ask, they listen, and then offering up some more innovative solutions. And so I'm really excited about where the relationships have gotten to in this very stressful period. And probably that's the most exciting thing that I think is coming out right now.
We had talked a little bit pre-podcast, just the Midland floods up your way, up close to where you live and such. Was the HIE active in support around that too? Because I assume you had people that were displaced.
We were active, but there was not much that people asked us for. I mean, we were fairly well deployed, so there was a lot of business as usual, but we didn't get asked for anything in particular, and largely because the hospital in Midland had prepared years ago for the floods, because they'd had floods before, and so they were not moved like in a Louisiana, New Orleans kind of situation when they were flooded, so that they were able to stay using all of their standard systems and things. But had they been forced to evacuate or something, that could have been a big deal.
Got it. Okay, very good. I did work way back when during Katrina, and where you had a diaspora, right? Mm-hmm. And just getting information out across 4 or 5 states where the majority of people fled from New Orleans. It was just an absolute nightmare and things. Jocelyn, any thoughts on that in terms of interoperability and such?
I had a couple of questions I actually wanted to ask Tim, because I think he gets to the heart of something. We've discussed a recovering product manager. So I always think in those sort of terms about sort of how are you solving the current problem. And I really appreciate sort of your conversation around meeting people where they are in reality from a technology perspective. I have a nephew who is actually one of those National Guard guys out testing folks. So I appreciate sort of, in a lot of military in the family, sort of the interaction and imagining what that was like. To me, I think one of the powers of emergency, though, is that it literally lets artificial barriers drop, right? And so I think that we have so much that's held us up, sort of veiled under the sort of roof of HIPAA, but has been around defending business models or sort of access to information. And you guys really have unlocked that, I think, in Michigan in a really meaningful way. So can you talk a little bit about, what you think the drivers or the ability was to be able to onboard all those new people to the network and to really release sort of what would have been, or is, as you come out of it, what the output of that will be, of sort of those pre-existing sort of organizational security concerns that get thrown up whenever we try and do sort of new and innovative projects?
Yeah, well, look, we still have 2 problems: Quest and LabCorp. Okay, their business practices are they don't want to share the data back to everybody else in the community. They want to share it with the ordering physician alone, and then say the ordering physician, if they can figure out how to do that, then that's great. And so I think we're very close to getting those 2 solved, but it's taken government intervention to do something that shouldn't have required that. It's a bit of a conflict with the business model. So both those organizations have been very difficult in that process. On the flip side, Abbott, BioReference, all these other folks, room, and then some of them are super sophisticated and doing a great job. And so I think certainly for us, our existing hospital labs have really stepped up, and they're doing a really world-class work. But we're seeing some of those big national labs who are getting a lot of national attention and a lot of the national funding actually not really being very helpful to us on the ground. And so I think there will be some retribution for not being a good contributor when we needed that. And it wasn't we needed it at the HIE, it was the community needed it, and these guys weren't that helpful. So I think you'll see health plans around the state reevaluating, gee, should we be really working with these guys quite the way we were? So
you and I should catch up offline, Tim. The folks at United actually did a really great demo this past week on the community roundtable for Da Vinci, actually doing a lab chase. I don't know if you were able to join the call, but I'd love to connect with the folks over there because they're using the CDEC standard to basically pull that data out via FHIR. So,
and again, it's not the getting it. It's not. We have plenty of ways to get it. It's the ability to sort of use it the way we want to use it. And that's the real problem, not technical, business. So, but I still want to. The other one is telehealth is not going to go backwards. And I think when we look at Care Alliance and when we look at consumer access to data and actually having consumers involved in their healthcare, the telehealth platforms, it's not the Zoom part, although people are getting more comfortable with that. It's this idea of virtual care and interaction with texting and moving back and forth. And so I think dropping those rules nationwide, I think both Medicare and Medicaid across the country have done everyone a service, because there's a whole bunch of stuff nobody should have to go back to doing that when they change some of those rules, we now can do. So, those changes are going to drive the innovation more than anything I've seen.
Yeah, I find it interesting that when you talk about data blocking, right, when you kind of have that conversation normally, everybody points at the EHRs, right? Like, you guys are, and I'm not going to name any specifically, but you guys are data blockers, and whatnot. But it's really a much broader conversation because, you throw in labs, you throw in, private radiology clinics, you throw in all these home health, you throw in all these ancillary services, and a lot of them even technologically can't or don't want to, but a lot of them just policy-wise don't want to do it and whatnot, and that kind of catches you too. So it's in the mindset of free the data, it's kind of all the data, not just the EHR data.
I can honestly say in Michigan, we have never found Epic or Cerner or at all, even remotely, a problem for being able to share data. So I have seriously questioned who is doing the data blocking. The difference that I can see in Michigan is that some of these large Epic customers or Cerner customers had $1 million plus incentive on the table to make it a priority. And we never had a problem with people saying technically that can't be done. So I seriously question that that was ever the issue for data blocking. Maybe it was. It certainly wasn't our experience here. So I think it's a combination of the business case and the technical capability intersecting that needs to be observed. And I think most data blocking going forward will be total business case.
Got it. Let's talk a minute or two about pandemic surveillance. So other countries such as South Korea and Taiwan, they've been phenomenally successful in terms of, controlling the spread of COVID, leveraging things like cell phone geolocation and things like that. Do you see HIEs getting into it? Maybe I'd like to start with Ken on this because I think he has a pretty global perspective on these sorts of issues. So Ken, maybe a little bit of talk about pandemic surveillance and what's been going on and how we see that play out. And then Tim, we'll go to you to kind of talk about the Michigan market in terms of how you guys think about it there.
Well, let me speak to this issue of data privacy and security and tracking, because this seems to be a big component. Uh, it's actually a shock, I think, when most people see just how much information Google and Facebook and Amazon have about us, which is both good and bad. Uh, how much the government knows about us, maybe not so obvious, but I tend to think they know more than less, and that's a little concerning to do. The consent, sounds good. Well, I'll be able to decide who gets to see my information, and all these apps will give me the opportunity to make all these selections. But I've been working, started with mainframes 40 years ago. I'm pretty technically astute, and trying to manage all these different settings on my smartphone and the apps and the platforms I'm on for what can or can't be shared, you get lost. And those policies and those settings are constantly changing as well. So that's a very complex area. Now, will patients, for example, want to activate an app on their phone that lets them be tracked and traced and know who they're around and so forth? I think there are people who will agree to that, especially if that's their ticket, into the sporting event or into the concert. But there are plenty of people who won't go for that. I just had a friend send me a message on Facebook that said, don't. Remove me from every one of your contact lists because I don't want to be part of any of this. And I think that's not going to be an uncommon point of view. Now, this is, I think, interesting. Here in New York State, we have our interstate system, the New York State Thruway, and we have a transponder system on that thruway, and you got to opt into that. There are certainly some benefits to being part of it. You don't have to deal with cash and so forth. But there were certainly people who didn't want to be tracked. But guess what? Now they have cameras mounted. In fact, they're not even going to use the transponders. They're basically going to take a picture of your license plate. So where did the opt in or opt out, go there? And when we start looking at what's going to happen in healthcare, are we really going to be in that different a situation? Will the greater good override any type of privacy or security consent that we think we can give? So, Tim, what do you think of that?
So first of all, I think opt-in and opt-out are really archaic concepts, okay? And I think they're easy for people to get their head around. Oh, I want to be in or I want to be out. But I think that is really, in modern society, an unsophisticated way to approach I need the system to meet my expectations, okay? And so I think there's a much better framework that ranges from the kinds of choices that people and patients want made, whether that's this is my advocate, for when I'm unable or incapacitated to take care of myself, to this is an advanced directive where I've got COVID and I'm worried, to this is how I want you to handle the use of my information, okay? And I think as we blend HIPAA with regular consumer protections, that we've got to get a more comprehensive and integrated approach to sort of how we say this is the continuum of choice that's available to patients. But doctors have choices too. And, one of the biggest discussions that I usually get into when we talk about data sharing is this weird dialogue between the general counsel of a major health system and the chief medical officer, where the general counsel says, well, patients have the right to do this. And the doctor says, that's true, but they can't tell us how to practice medicine. So if they consent to actually receive the care that we render, there are some expectations that have to be met. And I think that sophisticated interaction and dialogue doesn't get captured with a lot of the framework that people need. And I think the only way you can manage that sort of sophisticated space is with these new APIs, with these new tools and mechanisms to integrate with the workflow and to integrate with consumer apps. And so I simply don't believe we've had the technology until very recently to be able to manage this complex space. but I believe we now do. But we have not got the business or the workflow process anywhere close to be able to say, this is what we want to do.
You mean we can't manage consent by emailing spreadsheets around to each other? I mean, that was working for the pandemic. I don't believe we can, actually. And we still have some basic concepts of identification of who you are, patient matching, that in order to do consent well, we really actually need to know who you are in an electronic digital space. And if we're not confident of that, you know what it's called when somebody, quote, gives consent and it's not really them and your data flows to somewhere else? It's called a breach. And so, I mean, we have a lot of homework that we have to do in this space yet. And I don't believe that work has even really fully begun on a national level yet.
I look at how relatively simple a lot of this stuff is in the financial services world. Granted, not as complex a vertical, but still, when I go online to my broker or whatever, I get authentication done to my cell phone, real time, right there, two-part authentication and whatnot. I get a text every time something changes, something sold, somebody touches the account, hopefully it's me, things like that. Like, why can't that be done in the world of healthcare? Anytime somebody accesses my record at a given system, why can't they just ping me and say, hey, somebody's accessing your record, just letting you know?
Yeah, they can. The dirty secret is, though, that the financial industry writes off billions of dollars of losses. How do we actually account for that with people whose whole lives are changed?
Yeah.
Right.
Yeah.
We can't go backwards. Okay. And
right.
So it's not an accounting loss that you can write in. So it has to be taken through a different mindset because it's a one-way path. And so it's very complicated. And even worse is, I don't care, just take care of me. Take the best possible care of me is the other side of that. So the last thing we want is any hurdles between the person who's going to save your life or make your life better and that hoo-ha, right? And so we've got both ends of the spectrum that are really a challenge in healthcare that very few industries have at the level we have.
Yeah, very good. Jocelyn, you want to?
I was just going to say, I think that the analogy to finance is interesting, having grown up there. I think that there is a big difference between the hassle it is when your card gets breached and you have to get a new credit card and re-update it across all of the places that automatically debit you every month versus, if your information gets breached from a healthcare perspective, sort of once the genie's out of the bottle, it's out of the bottle forever. But I think that there's another factor too, and I don't want to oversimplify, but the reality is, Gary, when I'm working with my finances online, it's between me and my bank, right? Or it's between me and my bank and my bill pay. But there's not interactivity about my banking data offline without me in the way that we're expecting multi-party interactivity between our care teams in healthcare, especially when we talk about our most vulnerable populations, right? Where you've got proxies and you've got long-term care and you've got all these ancillary care professionals that are really imagine if all of a sudden you had 10 different companies needing to access your bank account versus just you trying to get online, to your JP Morgan account. So I think that there's a distinction, and I'll often give healthcare a hard time for not sort of being as far advanced as other industries, but there's a complexity in sort of the actual model of number of people touching the same data and all of the rights and permissions that are around that really doesn't exist in many other places.
Yeah, we probably don't have anything as sophisticated in healthcare. When you think of credit scores, that's probably the best analogy to searching for information about your finances, whereas in healthcare, we're always searching for information about your health.
Got it. I want to kind of continue down this thread here and jump ahead a little bit. So how do you all think about consumer digital apps now? So if we're going down this thread of the consumer being involved and whatnot, Tim, you want to start us off on that? And do you see the HIEs being conduits for data getting to these consumer digital apps, be it Apple Health or be it Fitbit Health or be it whatever down the line, or how do you fit into that?
Yeah, so I think the private right of access evolution is going to become sort of more real for HIEs as well. Okay, a lot of HIEs, I think ourselves inclusive, have never had a portal. We've never offered a consumer-facing solution, partially because hospitals are really threatened about stealing their patients, to be blunt. But you know, I think a lot of it too is dealing with identity and sort of setting that up. The way we see this working is through a combination of telehealth, where we're deploying consumer apps to their home, to their iPhones and Android phones. So we're kind of already facilitating and helping broker that relationship with the consumer back to their doctor and consent. And so between consent and sort of helping get their doctor the clinical information from the rest of the space, we're sort of gradually going in to how do we facilitate this. The big question that we have as well is, can you trust all the consumer apps that are out there? How do you trust them? How do you validate them? And what's the right forum for that to work? And so what we're really trying to do is build a trust model. We're actually looking at the Da Vinci framework, really, as we look at sort of OAuth and all that. But using the payers and the process to sort of get at and share information, as well as some of the Karen, alliance pieces for consumer access, to see if we can establish a trust model that's reusable, at least at the scale of Michigan, that's keyed off of, and this is probably a really important component, this active care relationship service. And I don't have time to explain it, but I'll just say, if you know what attribution looks like, where you kind of say this doctor and this patient go together, right. Imagine that you have prospective attribution where you've said, okay, these people are expected to want to talk to each other in the future. They're expected to want to get information about the patient. Now we have a higher level of trust when somebody who's expected to want to look for the information for a patient actually wants to look for the information for a patient. We don't quite have that yet for the apps, but the expectation we would have is that apps would essentially register into that service just like an Internet of Things kind of device that is joined in with, okay, this consumer has these relationships with these apps, if that's an Alexa or whatever it is, and these providers. Now we'll have our cybersecurity and our monitoring and our authorization tools kind of take a comprehensive view of what's the probability that this one is a hoax. That's how we think we'll get to trust in that space. But what we'll do is anything the patient has a relationship with, apply as a sort of formula for release of information, score how high a confidence we have that it's really that person, and we're good to go. So for us, it's sort of, just more, and we don't view it as what can't people do with their information. We view it as our job is to make sure that consumers' expectations are broadcast as broadly to all of the right actors in the ecosystem as we can find.
I'm just going to mention, I think your points about these third-party apps and what you said before about information blocking, they're like two categories of this. One category would be, EHR to EHR or provider to provider. But this point about third-party apps that want to gain access to this information, those were the folks I think that were yelling the loudest. And in the name of competition, I think, and consumerism, the government put their vote there.
I think the government most definitely put their vote there in a big way. I mean, I think if you look at the ONC rule, it really is so heavily focused on patients' rights to their own data. And even the CMS side of the rules were about payers getting their act together and making sure that patients and providers don't have to jump through hoops to get information about patients during transition points. So, I mean, I think that there's a big vote there. I think the thing that makes consumer apps so much more complicated is really sort of the, who and how are they going to get access to the data? Tim, I love the way that you've positioned that, because I think that to me, the question is will consumer apps view HIEs as consolidators to get information from all these endpoints, or will they continue to knock on the front door of the payers and the front door of individual provider systems through their individual patients to get access? This whole concept around who to trust and who not to trust, the security, the certification, the validation of the app itself, not even necessarily the individual that's requesting access, I think is going to be critically important, because it puts us in a whole new world that most people haven't operated, right? This is all under FTC. It has nothing to do with the Office of Civil Rights and HIPAA. It's all under, Federal Trade Commission. So I think that there's a lot to be figured out. To me,
And by the way, Jocelyn, it's under that other category, which means it's worthless for healthcare, because basically licensure and healthcare are under HIPAA. And so all of this great work we've been doing is exactly what we fail. It's repeating the same mistake that we did under meaningful use. Everybody can push the data out, but absolutely no one has figured out the process to take it and push it back in.
I know.
Because I want my medical information in my own hot little hands so I can give it back to my doctor. Okay. And so the problem is that nobody has spent any energy in putting the data back in, from a business perspective or a technical perspective, into all these other work streams that are going to help me. And so, I think consumers' concern that all the data is coming out, going to consumer spaces, creating brand new opportunities for those folks outside of healthcare, and lots of big data AI type visions. It's unclear how consumers are going from a healthcare perspective to directly benefit from that. Not that I don't think they will, because I'm a big power on free the information and good stuff happens.
Right.
However, there's more work in the healthcare space to sort of make that really thrive. And I think that's going to happen next. Maybe that'll be 2022, whatever the next cures, cares follow on is.
Right, very
I
good.
think it's a great point, Tim. Thanks.
Guys, this was an outstanding conversation today. Really good. Tim, final word from you. What counsel would you give your HIE peers out there in a word coming out of COVID? What should they be thinking about?
I think it's time for the HIEs to look at finding a way to aggregate the relevant portions of our local worlds into something bigger than all of us. And obviously, I think Chiic's a key component in that. I think the patient-centered data home is a great example of what could be possible. But I think it's time to really take it up to the next level. And I think that bringing the local perspectives up to a national scale it gives you the power of aggregation. It gives you the power of not being disintermediated by anyone who's operating at a national level. And so I think there's a real opportunity to, think globally and act locally, so to speak. I don't think we've been thinking globally enough yet.
Yeah, being a snowbird as I am, it's painful, beyond painful, to deal with physicians in two different states and different sides of the country and things like that. So I hope we can get there. Ken, final thoughts from you for the day, and then Josh, I'll wrap up with you.
I think it's been said many times that we don't want the perfect to be the enemy of the good. we have major interoperability needs right now, particularly with public health reporting. I mean, the government's pretty good, I think, at solidifying standards around what's working, and they're not so much dreaming of new stuff for the future, and they're not particularly prescriptive about how to go about this. But their work, it takes time, and you have to find this right balance between innovation and execution. So leveraging the progress of some of the more advanced organizations like MiHIN, I think with what they've already developed is really going to make a difference for us today.
Great, excellent. Josh, final words.
So I always enjoy listening to what Tim's up to in Michigan. And I think to Ken's point, I think they're doing a great job of pace setting for HIEs across the country. To me, if you look at the combination of the ONC and the CMS rules, plus this emergence of really more flexible, viable standards to move us to APIs, I think really provides the opportunity for HIEs of all types to be able to grow and expand their role and the criticality that they play within their individual markets. I think Tim has continued to innovate in his market. We get to see other folks that have been doing that. I think what will become important is people that can master those core services, I think that Ken referred to, that ability to really be sort of that center place where people are getting the security, the identity, the traceability that they need in order to make these transactions happen in a real way. The HIEs that build on the final rules, the people that fill the existing gaps in their market to be connectors and enable their partners to look compliant as we sort of roll through the next couple of years, I think will be the people that are winning.
Excellent. Very, very good. Be sure to subscribe to us at whatever podcast carrier you use, Apple, Spotify, Google, or whatever. If you have any speaker thoughts or if you have any comments or suggestions on this podcast, email us at podcast@pocp.com. Goodbye for now, and remember, health IT is a dish best served hot. Good day, everyone.
Thank you for listening. If your organization needs help understanding and planning for the Trusted Exchange Framework and Common Agreement, or TEFCA, reach out to us at info@pocp.com.